Good day, everyone. We are Group 1 from Section B, and we will be discussing about the universal and standard precautions in personal protective equipment. Course Learning Outcomes. CLO number 1. Differentiate universal precaution and standard precaution. CLO number 2. Discuss comprehensively the healthcare facility recommendations, such as guidelines and practices, under standard precaution. CLO number 3. Discuss the various PPEs used in standard precaution in terms of its description and guidelines when using. CLO number 4. Differentiate respirator fit test versus seal check. CLO number 5. Explain post-exposure prophylaxis or PEP for HIV, hepatitis B and C in health settings in terms of definition and benefits of post-exposure prophylaxis, risk of post-exposure prophylaxis, general approach to management, and treatment protocols.
Hello and good day. My name is Utazame B. Judaya,
And I'm Franz Raven T. Boylas.
and we'll be reporting about the differences between universal precautions and standard precautions. Universal precaution. Universal precautions involve precautions that are taken with all patients regardless of suspicion of infection that aids to prevent the spread of bloodborne pathogens. Next, universal precautions refers to the concept that all blood and body fluids should be treated as infectious because patients with bloodborne infections can be asymptomatic or unaware that they are infected. To avoid the transmission of bloodborne infections, universal precautions are taken for all patients regardless of infection suspicion. According to the Occupational Safety and Health Administration (OSHA), the use of universal precautions control occupational exposure to bloodborne pathogens. Lastly, these are practically controlled guidelines designed to protect workers or oneself from exposure to diseases spread by blood or other body fluids through direct or indirect contact.
Good day again, everyone. I'm Franz Raven Boylas from BSN1B, and I will be discussing standard precautions. Standard precautions are steps designed to combat and stop the spread of airborne pathogens in circumstances where healthcare providers come in contact with any type of bodily fluid from the patient. Standard precautions are integrated and expanded form of universal precaution. These include organisms spread of infectious diseases, come in contact with blood, plus all body fluids, non-intact skin, mucous membranes, secretions and excretions except sweat, regardless of whether they contain blood or not. These procedures are intended to keep dynamic host configuration protocol protected while also preventing infection spread among patients. Standard precautions involve education and training to assist DHCP in making better decisions and strict adherence to recommended practices.
An approach of universal precaution is the body substance isolation or BSI. The BSI approach characterizes all moist body substances as potentially infectious. This also identifies certain measures or steps that are to be taken whether or not an infectious diagnosis is identified. Lastly, this is also the practice of isolating all body substances of individuals receiving medical care, particularly emergency medical treatments of those who may be infected with illnesses such as HIV or hepatitis in order to minimize the risk of transmission as much as possible.
An approach of standard precaution. Transmission-based precaution is a second tier of infection control used in addition to standard precaution. These are protocols made for patients who are infected or colonized with infectious agents, such as when patients have diseases that spread by contact, droplet, or airborne routes. Example of this contact is through skin contact, sneezing, or coughing. Since the pathogen is often unknown at the time of admission to a healthcare facility, transmission-dependent precautions are used empirically based on the clinical syndrome and possibly etiologic agents at the time of admission. And this is only adjusted until the pathogen is identified or a transmissible infectious etiology is ruled out.
Good day. For CLO number 2, we are to discuss the healthcare facility recommendations for standard precautions. And the reporters are Regilu Cordero, Zaira Cabriles, myself Enrique Larazabal, and Trixie Fallier. We have to use standard precautions for the care of all patients. We have to assume that every person is potentially infected or colonized with an organism that could be transmitted in the healthcare setting. We will now be discussing the different standard precautions practiced in the hospital setting. 1. Hand hygiene, which is the most important and most basic technique in preventing and controlling infections and preventing the transmission of pathogens with the use of plain soap or antimicrobial or antiseptic agent. There are two types of hand hygiene, which are the hand washing and the hand rubbing. Hand washing usually takes 40 to 60 seconds and when hands are visibly soiled. Hand rubbing takes 20 to 30 seconds when hands are not visibly soiled using an alcohol-based hand rub. It is important to note that we do hand hygiene before and after any direct patient contact and between patients, whether or not gloves are worn. We also do it immediately after gloves are removed because the gloves might contain small tears or hands might get contaminated while removing the gloves. It is also done before handling an invasive device to prevent pathogens to enter patient's body. We should practice hand hygiene after touching blood, body fluids, secretions, excretions, non-intact skin, and contaminated items even if gloves are worn. It is done during patient care when moving from a contaminated to a clean body site of the patient to prevent cross-contamination. It is also done after contact with inanimate objects in the immediate vicinity of the patient. Another standard precaution being practiced is to wear gloves. Wear gloves when touching blood, body fluids, secretions, excretions, mucous membranes, non-intact skin. We have to change between tasks and procedures on the same patient after contact with potentially infectious material. This reduces transfer of microorganisms. We have to remove it after use before touching non-contaminated items and surfaces and before going to another patient. This prevents further transmission and spread of pathogens. Another standard precaution is the facial protection, which includes our eyes, nose, and the mouth. We have to wear a surgical or procedure mask and eye protection, including the eye visor or goggles or a face shield. This protects the eyes, nose, and mouth from splashes or sprays of potentially infectious materials. For eye protection, we have to wear goggles or disposable or non-disposable face shields. And for the respiratory protection, we have to wear a respirator with filtration because this prevents inhalation of infectious particles. For mouth protection, we have to wear masks. This protects healthcare personnel from contact with patients' pathogens. This also protects patients from exposure with healthcare workers' pathogens. This limits potential dissemination of infectious respiratory secretions from coughing patients.
Number 4 is gown. Wear a gown during activities that are likely to generate splashes or sprays if potentially infectious material. Example: blood, body fluids, secretions, excretions, and etc. The purpose of it is to protect our skin and prevent soiling of clothing. Second is remove soiled gown as soon as possible and perform hand hygiene. It is to prevent possible contamination of the environment. The outer contaminated side of the gown should be turned inward and rolled into a bundle and properly discarded. Number 5 is prevention of needle stick and injuries from other sharp instruments. Use care when: first is handling needles, scalpels, and any other sharp instruments. It is to employ safer techniques, example, not recupping, bending, removing, shearing, and breaking sharps. Second is cleaning used instruments. Third is disposing of used needles and other sharp instruments. Dispose in sharp disposal container, rigid, puncture resistant, leak proof, disposable, and marked as red in color. Number 6 is respiratory hygiene and cough etiquette. Source control measures. First is cover nose and mouth when coughing or sneezing with tissue or mask. Use handkerchief or elbow, not hands, and also avoid spitting. Second is dispose used tissues and mask in nearest waste receptacle. Lastly, perform hand hygiene after.
So hello, good day everyone. I'm Regulo Polef Cordero and I'm gonna report the guidelines 7 and 8 in healthcare facility recommendations for standard precautions. So 7. Environmental cleaning. The hospital must have and employees must comply with adequate procedures for the routine care, cleaning, and disinfection of environmental surfaces such as bed rails, bedside tables, commodes, doorknobs, sinks, and any other surfaces and equipment that are frequently touched and in close proximity to patients. This is intended to prevent accumulation of harmful microorganisms that can be detrimental to both the patient and healthcare personnel. So for guideline number 8, linens. Textiles such as bedding, towels, and patient gowns that have become soiled with blood, body fluids, secretions, or excretions must be handled, transported, and laundered in a safe manner. Handle, transport, and process used linen in a manner which prevents skin and mucous membrane exposures and contamination of clothing. Avoid transfer of pathogens to other patients and or the environment. Soiled textiles must not be shaken, must not come in contact with healthcare workers' body or clothing, and must be contained in a laundry bag or designated bin in order to avoid contamination of air, surfaces, and persons.
For healthcare facility recommendations number 9 and 10, I, Zara Sicarbiles, will be the reporter. Number 9, waste disposal. Healthcare waste should be properly disposed and segregated to reduce the amount of waste that must be treated as hazardous waste, to reduce the risks of exposure to hazardous healthcare waste for workers, to lower the cost of treatment and disposal of healthcare waste, and to make possible the recycling of non-hazardous general waste. So for waste disposal under standard precautions, it is important to ensure safe waste management, treat waste contaminated with blood, body fluids, secretions, and excretions as clinical waste in accordance with local regulations. Human tissues and laboratory waste that is directly associated with specimen processing should also be treated as clinical waste. And lastly, discard single-use items properly. According to DOH, the following are the segregation of healthcare waste according to types of waste and sources. Red for sharps and pressurized containers. Under this are needles and syringes, scalpel blades, glass vials, capillary tubes, ampules, test tubes, empty aerosol cans, rusty pins, nails, clips and screws, broken glasses, and etc. Yellow for infectious and pathological wastes. Examples under this are gauze, cotton bandage, cotton applicators soaked with blood and body fluids, foreign bodies removed from any body parts, placenta, umbilical cord, used gloves, used urine bags, used diapers and sanitary napkins, used mask or face mask, used bandages, specimen containers, used culture media, and etc. Yellow with black band for chemical and pharmaceutical wastes. Under this are empty bottles of acids such as hydrochloric acid, sulfuric acid, nitric acid, and etc. Empty bottles of betadine, iodine, KMNO3, empty bottles of laboratory reagents, empty bottles or cans of kerosene, acetone, alcohol, and anesthetic, empty bottles of disinfectants, defective thermometer, expired and adulterated drugs and medicines, used batteries, and etc. Black for non-infectious dry waste. Under this are paper and paper products such as newspapers and boxes or cartons, bottles, packaging materials such as styrofoam, aluminum, plastic, candy or food wrapper, and etc. Green for non-infectious wet waste. Examples under this are kitchen leftover food, used cooking oil, non-infectious leftover foods, fruits and vegetable peelings, rotten fruits and vegetables, and etc. Orange for radioactive or nuclear waste. Under this are used X-ray films, developers and fixers, 1125 or iodine 125, things contaminated with radioactive materials such as gloves, tissue papers, cotton swabs, gauze, test tubes, and etc. Number 10, patient care equipment. Organic materials such as blood, body fluids, secretions, and excretions must be removed from medical equipment, instruments, and devices prior to high-level disinfection and sterilization because residual proteinaceous material reduces the effectiveness of disinfection and sterilization processes. For patient care equipment under standard precautions, it is important to handle equipment sold with blood, body fluids, secretions, and excretions in a manner that prevents skin and mucous membrane exposures, contamination of clothing, and transfer of pathogens to other patients or the environment. Clean, disinfect, and reprocess reusable equipment appropriately before use with another patient in order to prevent cross-contamination.
Hello, my name is Bryce Mingoy.
Good day, I am Maria Chishley Amber E. Martinez.
I am Jackie Gillian El Salgado.
And we will be discussing CLO number 3, personal protective equipment used in standard precautions.
Clean gloves. We have four different types of clean gloves. First, we have the poly gloves, known as for the use of food preparation, used for personal care, mixing, pet waste, clean up, and etc. This is a latex-free and non-irritating, keep the hands clean, and moderately protect sensitive skin. For the second gloves, we have the vinyl gloves. Prevents from any allergies or sensitivities. This is designed for quick tasks and allows for fast and easy removal and replacement, specifically in busy medical settings. This provides limited protection against chemical or biochemical exposure. Lastly, most commonly used in non-hazardous and low-infection environments. Next is we have here the latex gloves. These gloves are preferably medical applications, most effective protection against bacteria, viruses, and body fluids. Provide the foremost fit and sense of touch. Has high tensile stretch or rather ability to resist tearing. And lastly, superior protection against pathogens. So we have here a photo. Last type of clean gloves is we have here the nitrile gloves. These gloves are recommended for high-risk work environments wherein chemicals are present. This protects the hands from any harsh corrosive chemicals which cannot be resisted by latex and vinyl gloves. This can handle moderate temperatures, and this has moderate protection against pathogens.
I am Jackie Gillian El Salgado, and I'm here to report to you course learning outcome number 3.2. Goggles. It provides barrier protection for the eyes. It protects our eyes against splashes of blood and body fluids when healthcare workers are performing splash-prone procedures. It is recommended as primary eye protection because they have been shown to significantly reduce transmission of infectious diseases. Goggles should fit snugly over and around the eyes or personal prescription lenses. Goggles with anti-fog features will help maintain the clarity of vision. Chemical splash goggles. It is recommended as any time a splash of chemicals or infectious substances could reach the eyes. It also acts as an impact goggles to prevent debris from reaching the eyes. General safety glasses. Must have side shields or a one-piece lens that wraps around the temple. It has a minimum level of eye protection that must be worn in the laboratory. It is not effective in protecting the eyes from splashes and are only recommended for the use of solutions that are not likely to damage the eye, such as some buffers and salts. Face shields. It should be used during patient care activities that are likely to generate splashes and sprays of blood, body fluids, secretions, and excretions. It protects the face, nose, mouth, and eyes. It should cover the forehead, extend below the chin, and wrap around the side of the face.
Hello, my name is Bryce Mingoy, and today I will be talking about the several types of face masks and their uses. So first off, we have the cloth masks, and it is basically the standard and disposable face mask which is commonly used for daily usage within the public. It is always recommended as well to be used during this time of pandemic and is always utilized in day-to-day activities that require a mask for basic protection. Next off, we have surgical masks. These are FDA-approved masks which are commonly used by doctors and other healthcare workers. These cannot be washed, so it is only to be used once per mask. It is a flat or pleated mask that is often used for surgical purposes to protect the user from respiratory infection that is basically from large respiratory droplets and is often used together with proper hygiene and medical hand washing to ensure its effectivity. It is typically used during surgical procedures as well and other healthcare purposes, but can be helpful in pandemics as it can be used to protect the wearer against respiratory infections. For the third mask, we have the N95 masks. These masks can filter 95% of air particles and can be essentially used for protection against most airborne illnesses. These are tightly sealed respirators that protect the user from most droplets in the air, and significantly effective as well in usage when professionally fitted, which is a service that is currently unavailable to the public. It is also essential, very essential towards healthcare workers, and so public use is discouraged just to conserve PPE for more urgent cases. So the next mask that we have is the KF94 mask. These masks can filter 94% of air particles that are down to zero point 0.3 microns in terms of size, which is ideal for everyday usage or other situations that require respiratory protection against particles and possible pathogens in the air. So this mask is not NIOSH approved, so its usage may vary in official medical settings. And lastly, it is quite effective in comparison to other masks, most especially to the commonly used cloth masks. So this would be ideal as well for day-to-day usage. So the next mask is the KN95 mask. This is usually considered the Chinese version of the N95 masks, which are also 95% effective in terms of protection from air particles. This is not NIOSH approved, so its usage in official medical settings may vary. So, despite being 95% effective as well, it is not generally considered better than N95 masks in terms of efficacy in filtration. Its usage is recommended for those who have a hard time in breathing through other masks, as it is easier to breathe through due to its structure, wherein there is a small space for the air between the user's nose and its fabric. The next mask is the elastomeric masks. So elastomeric masks can either be half face pieces or full face pieces. So its usage may vary depending on the availability or the preference of the wearer. It is non-disposable and it is repeatedly used as long as it is properly maintained through cleaning, disinfecting, and proper storing. It is also equipped with replaceable filters to ensure safe usage, and these masks are commonly used in home improvement projects. It can also be a good alternative, though, when using these masks for protection due to its reusability. Lastly, we have the powered air purifying respirator. So these type of masks can remove any particles ranging from dust to fumes and other toxic gases in any setting by utilizing the particle filter inside it that removes any unwanted substances, and then an electric fan inside pushes the purified air down towards the user. So due to its high protective performance, it is quite easy to breathe in and is ideal in most settings that require a high level of protection. It's also mainly used in working environments but can also be relevant in protection against airborne illnesses.
I am Hisha Frame Demaclade, and
I am Marian V. Saniza.
And we will be discussing how to differentiate respirator fit test versus seal check. I am Hisha Friend Macleod and I will be discussing about the respirator fit test. A fit test assesses the seal between the N95 mask or respirator, face piece, and the face. It takes between 15 to 20 minutes to complete, which should be done the first time to use the sort of mask and again at least once a year after that. The fit test must be carried out for the same make, model, and scale of mask the worker would be wearing on the job. Fit checking for a mask that isn't the same as the one that will be worn does not ensure adequate safety. If the mask used for the fit test does not fit properly, another make, shape, type, or scale of mask must be tried before one that does. In the respirator fit test, there is qualitative and quantitative checking. Qualitative respirator fit testing. The ability to smell and or taste a spray solution or smoke is the sole focus of a qualitative mask fit testing. Half-mask respirators such as the N95 are commonly subjected to qualitative fit checking since they only protect the user's mouth and nose. Qualitative fit checks are graded on a pass or fail basis and do not take into account the level of leakage. To detect leakage, they depend on the user's sense of taste or scent as well as the person's response to an irritant. This can be achieved in one of four ways: irritant smoke, Bitrex, isoamyl acetate or banana oil, or saccharin. Quantitative respirator fit testing. Quantitative mask fit testing, on the other hand, is a far more accurate procedure that determines whether or not it has the right mask size by using a scanner rather than just a sense of smell and or taste. The unit called is called a porta count and it determines how well the respirator suits the wearer by measuring the temperature of the air inside and outside of it.
I am Marian V. Saniza and I will be talking about performing a seal check. So, a user seal check is a procedure that is performed to confirm that a tight-fitting respirator is properly sealed against the face of the wearer. Each wearer of this type of personal protective equipment, or PPE, must perform a user seal check whenever he or she puts on a tight-fitting respirator. This is done to find out if the respirator is being properly worn or seated on the face. Even though you have a fit-tested respirator, user seal checks are also required to help you ensure that you have an adequate seal every time you put the respirator on. The user seal check can either be a positive pressure or negative pressure check. For positive pressure check, the respirator user exhales gently while blocking the path for air to exit the face piece. A successful check is when the face piece is slightly pressurized before increased pressure causes outward leakage. For negative pressure check, the respirator user inhales sharply while blocking the path of air to enter the face piece. A successful check is when the face piece collapses slightly under the negative pressure that is created with the procedure.
CLO number 5, post-exposure prophylaxis for HIV, hepatitis B and C in health settings.
Good day everyone, I am Maria Jurizati Ubas and I am going to report about the definition and benefits of post-exposure prophylaxis.
So, what is PEP? Post-exposure prophylaxis is preventive management to avoid infection subsequent to exposure to human blood and body fluids that may transmit human immunodeficiency virus, hepatitis B virus, or hepatitis C virus. Management of such exposure is disease-specific. PEP for HIV may involve antiretroviral therapy. PEP for HBV may involve both passive and active immunization against HBV. Post-exposure management for HCV may include testing and follow-up only. PEP for HIV. It should be initiated as soon as possible, maximum of 72 hours after the exposure incident, if indicated based on the nature of the exposure incident, and even while awaiting testing results for the source person, no laboratory evaluation is required prior to initiation of HIV PEP. It is indicated if the exposure type is moderate to high risk and the source person has a substantial risk of having transmissible HIV infection. If the source person is of unknown HIV status but at high epidemiologic risk or is HIV positive and unavailable or does not provide consent for additional viral load testing or verification of undetectable status, an assumption of a substantial risk for transmissible HIV infection must be made. Example situations in HIV PEP: first, unknown source person, example given, needle in sharps, disposal container, or laundry. Use of PEP to be decided on a case-by-case basis. Consider severity of exposure and epidemiologic likelihood of HIV exposure. Do not test needles or other sharp instruments for HIV. The other one is known or suspected pregnancy in the exposed person. The risk of HIV transmission poses a threat not only to the mother but also to the fetus and infant, as the risk of the mother-to-child HIV transmission is markedly increased during acute HIV infection, during pregnancy, and breastfeeding. Do not delay initiation of PEP while awaiting expert consultation. PEP for hepatitis B virus. The management of potential exposure to HBV should be based on the immunization and antibody status of the exposed person and the infection status, if unknown, of the source person. HBV vaccine is the most important intervention, providing 90% of the protection from HBV. Hepatitis B immunoglobulin, through immediate short-term passive immunity, may provide additional protection. Hepatitis B immune globulin and HBV vaccine can be administered simultaneously at separate injection sites using separate needles and syringes. PEP for hepatitis C virus. No post-exposure prophylaxis has been demonstrated to be effective against HCV. Also, the marked genetic diversity and multiple mechanisms of persistence of HCV, combined with relatively poor immune response of the infected host against the virus, are major barriers to development of a vaccine. Close follow-up, post-exposure testing, and early treatment with direct-acting antiviral combination therapy in the event that HCV transmission occurs are recommended for HCV post-exposure care. To summarize, HIV PEP should be offered within hours from exposure and for 28 days duration. Counseling is crucial to discuss true risk and benefits of PEP. Providers should choose 2 or 3 drug HIV PEP regimen based on exposure and source. Hepatitis B virus PEP involves hepatitis B immunoglobulin and hepatitis B virus vaccination.
Good day, I am Melanica Theres Mamanglag and I'll be covering the risks of post-exposure prophylaxis. First, for HIV, the potency of the antiretroviral drugs to be used often leads to side effects ranging from nausea and headache to potentially fatal conditions. Non-completion of treatment or missing a dose may also lead to resistance. With antiretroviral drugs and a series of testing, the cost of post-exposure prophylaxis can run up to approximately 12,000 pesos. Given these issues, there is a need for healthcare personnel to seriously assess all factors before commencing post-exposure prophylaxis treatment. Hepatitis B vaccination, the premier component of hepatitis B post-exposure prophylaxis, is relatively safe to administer, which also provides protection for up to 15 years. Typical side effects include pain in the injection site, fever, and temporary hair loss. The U.S. Vaccine Adverse Event Reporting System recorded a low rate of 1 in 600,000 cases of anaphylaxis, which is a life-threatening allergic reaction. As for hepatitis C, there is no vaccine against it. For healthcare personnel confirmed to be infected with hepatitis C and given interferon, they may experience flu-like symptoms. Other side effects of interferon include tiredness, hair loss, low blood count, moodiness, and depression. In severe cases, a patient may develop thyroid disease, severe depression, seizures, acute heart or kidney failure. The only means of prevention is strict adherence to standard precautions to avoid occupational exposure to blood-borne infections. So there are structures, policies, and supplies. All hospitals shall include hepatitis B and C into the existing HIV awareness campaign conducted by the HIV and AIDS core team and or the Infection Control Committee. 2. All healthcare personnel, like new entrants, employed in the clinical and ancillary departments shall be required to undergo a mandatory hepatitis B vaccination. All healthcare personnel currently employed in the clinical and ancillary departments shall be given free hepatitis B vaccination by the hospital. All cases of accidental exposure should be reported to the Infection Control Committee. It will assess and institute the decision whether or not to commence PEP. In case a hospital has separate HIV and AIDS core team, it will assume responsibility for providing HIV PEP and further counseling. 5. A referral network should be developed. The flow of network referrals starts at the case of accidental occupation exposure. First, we must ask, is the hospital capable of instituting post-exposure prophylaxis? If yes, then proceed to follow the steps as stated in the treatment algorithm. If no, we collect samples, appropriate samples from the source. Then, refer exposed healthcare personnel with source samples to the regional hospital or treatment hub nearest to the healthcare facilities. Perform screening process on the referred healthcare personnel and source sample. Lastly, follow up exposed healthcare personnel for assessment of response to post-exposure prophylaxis. For hepatitis B, where vaccines are available, the regional hospital shall determine the level of response and institute follow-up procedures and refer accordingly if procedures are not available. Proceeding to 6. All DOH treatment hubs should have PEP kits for HIV. Non-DOH treatment hubs, including private hospitals, can access the PEP for HIV upon coordination with the HACT. Hospitals and other healthcare facilities will shoulder the cost of treatment provided that the exposure occurred in the workplace and despite the healthcare provider's strict compliance with standard precautions and upon the joint recommendation of the ICC and the HACT.
Good day, everyone. I am Raimer Vela M. Ramas of BSN1B from Group 1. Today, I will be discussing about the general approaches to management for the post-exposure prophylaxis of HIV and hepatitis B and C. Steps in post-exposure management. Individuals who have evaluated themselves to have exposure to such blood-borne pathogens should be provided with immediate care. The post-exposure management for hepatitis B virus. The management of a person at risk of HBV from an exposure is dependent on their susceptibility to the infection based on history of prior infection and/or vaccination together with consideration of the source as a high risk or low risk. The HBV vaccination history and the vaccine response status of the exposed person should be reviewed and documented. Any person who has an exposure to HBV and is not immune or has never been vaccinated for HBV should begin the HBV immunization series immediately. Staff working in areas where they have a greater risk of infection through occupational exposures to blood and body fluid are encouraged to be immunized for HBV and have an anti-HBs to test within 1 to 6 months of completion of the vaccine series to verify immunity. If the staff members have been immunized for HBV but an anti-HBs has never been done, then one should be ordered. If the HBV test results of the exposed person and the source are not available within 48 hours, management of the exposed person should assume possible exposure. If indicated, HBIG should be administered to susceptible individuals within 48 hours after exposure. The efficacy of HPIG decreases significantly after 48 hours, but may be given up to 7 days after exposure for a percutaneous or mucosal exposure. The benefit of the HBIG given more than 7 days after exposure is unknown. However, it can be given to up to 14 days following last sexual exposure, due to a lower level of exposure. Where required, the recommended dose of HBIG for older children and adults is 0.06 milligrams given intramuscularly. Here is a table for the management of individuals with percutaneous or mucosal exposure to an infected or high-risk source. A known source is high risk if the person comes from a region highly endemic for HBV, has sexual relations with multiple partners, has a partner infected with HBV or at high risk of being so, is in close family contact with an infected person, uses injection drugs, or received blood or blood products prior. Wherever possible, the source should be tested. In this case, of an unknown source, background circumstances may provide some indication of the degree of risk. So the chart says, if the exposed person is immunized with documented immunity to HBV at any time or is documented as an immune from previous natural infection, no further action is required. If the person is known a non-responder to 2 courses of HBV vaccine, administer HBIG and repeat it in 1 month. If the exposed is a non-responder to 1 course of HBV vaccine, administer HBIG and a 2nd course of vaccine, which equals to 3 doses. If the person exposed has received 2 doses of vaccine, test for anti-HBs and give 1 dose of vaccine. If anti-HBs are negative or unknown at 48 hours, give HBIG. If anti-HBs show adequate immunity, consider the person as a responder in the future. If the exposed person has received 3 doses of vaccine but the immune response is unknown, test it for anti-hepatitis B. If the anti-hepatitis B show adequate immunity, no action is required. Consider as responder in future. If anti-HBs show inadequate response, give HBIG and 1 dose of vaccine. Test for anti-HBs at 6 months. If the result is unknown at 48 hours, give 1 dose of vaccine. When the result is known, if adequate immunity, consider as responder in the future. But if inadequate immunity, give HBIG. Test for anti-HBs at 6 months. If the exposed has not received vaccine, test for anti-HBs, give HBIG immediately and a course of vaccine starting immediately as well. If the exposed has received 1 dose of vaccine, test for anti-HBs, give HBIG immediately and a course of vaccine starting immediately as well. Omit an administration of HBIG if it is possible to obtain anti-HBs serology within 48 hours and a titer of at least 10 IUL is confirmed. When HBIG is indicated, it should be administered as soon as possible after exposure, preferably within 48 hours. However, it can be given up to 7 days following percutaneous or mucosal exposure and 14 days following sexual exposure. Lastly, when HBV vaccine is indicated, It should also be administered as soon as possible, preferably 48 hours, and can be administered simultaneously with the HBIG at a separate site. Vaccines should always be administered in the deltoid muscle. This one is another chart as well indicating for the management of individuals with percutaneous or mucosal exposure to an uninfected or low-risk source for hepatitis B. If the exposed person is vaccinated and is known to be immune to HBV, no action is required. If the exposed person has received 3 doses of vaccine but response is unknown, then test for anti-HBs. If immunity is adequate, no action is needed. If immunity is inadequate, give 1 vaccine booster and retest for anti-HBs a month later. If response is adequate, consider the person as immune for the future. If the retest shows inadequate response, complete the course of the vaccine, then test again for immunity at 1 to 6 months after vaccination is finished. If the exposed has had 3 doses and is a known non-responder, give the second course of vaccine. If the exposed has had 2 series of 3 doses and is a non-responder, no action is needed. If the exposed has been vaccinated with 1 or 2 doses only, then complete the vaccination schedule. And if the exposed person has been or has never been vaccinated, then vaccinate that person. Post-exposure management for hepatitis C virus, or it is also known as the HCV. There is no specific intervention available to prevent the transmission of the hepatitis C virus following an exposure. Immune serum globulin should not be given, as there is no demonstrated benefit. There is no evidence for use of antiviral agents in the HCV post-exposure setting, and such treatment is not recommended. In the absence of the HCV post-exposure prophylaxis, the recommendation is to closely monitor the exposed person for early infection and, if present, refer to a specialist for treatment options. Persons experiencing a needle stick injury from a known or high-risk HCV source should be monitored closely for symptoms of acute infection. When HCV transmission occurs, a person may have no symptoms, or they may become symptomatic and experience jaundice, feel unwell, and may display evidence of abnormal liver biochemistry. Up to 20% of infected people will clear the infection. The remaining 80% will go on to become chronically infected with HCV. Therapy for HCV can cure HCV infection in 40 to 90% of cases, depending on the HCV genotype. Treatment duration is dependent on the genotype and can vary from 24 to 72 weeks. After a positive HCV RNA test, the RNA test should be repeated at 12 weeks, post-exposure to confirm the presence of infection. This is the marker that determines the start point of treatment. For an individual recently exposed, it is especially important to diagnose HCV early so that referral to a specialist and treatment can be considered. Post-exposure management for HIV. The decision to treat with HIV PEP rests with the physician and the exposed person at the time of the assessment of the exposure, and should take into account the facts collected about the exposure and the source. The provision of treatment should never be based solely on the anxiety of the person exposed, as the drugs pose a risk of toxicity and side effects. As described by the BC Center for Excellence in HIV/AIDS, the treatment of a high anxiety level in the exposed person is reassurance, counseling, and education. It is not antiretroviral therapy. Antiretroviral therapy may be toxic and should be provided for medical indications only. The following information may be helpful in decision-making regarding PEP. When there is a doubt about initiating HIV PEP, treatment and consultation with an infectious disease specialist is advised.
Good day everyone, I am Roby Claire Villasuran from Group 1 and I will be discussing about the treatment protocols for post-exposure prophylaxis for HIV, hepatitis B, and hepatitis C. For HIV, the step 1 is the evaluation of exposure and risk assessment. In this table, we can see the type of exposures. The first one is the percutaneous exposure, and the second one is the mucocutaneous exposure. They are measured by their severity, specifically as more severe or less severe. In the next table, we have here the risk assessment. So there are 3 levels of risks. The first one is the high risk, moderate risk, and the low risk. In this table, we can see the procedure and materials for each level of risks. The step 2 is to determine the HIV status of source. So the status of source can be determined after proper counseling and testing. For HIV positive with low titer exposure, this is asymptomatic and they have high CD4 count and low volume. For percutaneous exposure and large volume mucosal exposure, it is recommended to start PEP. PEP once again means post-exposure prophylaxis. For small volume mucosal exposure, PEP is not recommended but may be given on request. It is also recommended to continue with the hepatitis B and C screening. For HIV positive with high titer exposure, they either have advanced AIDS, primary HIV, high viral load, or low CD4 count. For any mucosal and percutaneous exposure, it is recommended to start PEP. It is also recommended to continue with hepatitis B and C screening. If HIV is unknown, for percutaneous and large volume mucosal exposure, PEP is not warranted. Consider PEP if high risk factors are present, for example, setting in which exposure to HIV-infected person is likely. For small volume mucocutaneous exposure, no PEP is needed, but it is also recommended to continue with hepatitis B and C screening. For HIV negative, no PEP is needed, but it is recommended to continue with hepatitis B and hepatitis C screening. For hepatitis B, source is known to be positive if HCP has no prior hepatitis B vaccination or did not respond to a previous complete hepatitis B vaccination series. If HCP is a known non-responder after a second vaccine series. If HCP is yet to complete the vaccination series at the time of exposure. If HCP responded favorably to a previous vaccination series. And if HCP completed a previous vaccination series but did not undergo a post-vaccination testing. The status of source is unknown if HCP has no prior vaccination, if HCP is not yet completely vaccinated, and if HCP has completed the series. Source is known to be negative if HCP is unvaccinated, if HCP is yet to complete the vaccination series at the time of exposure, and if HCP completed a previous vaccination. In this table, we have the recommended vaccination dosage and schedule. We can see that 3 doses of hepatitis B vaccine are to be given in a 10 microgram or 0.5 ml monodose vial for infants, children, and adolescents at 0, 1, and 6 months. For more than 10 years old or adults, 3 doses of hepatitis B vaccine are to be given in a 20 microgram or ml monodose vial at 0, 1, and 6 months. Post-exposure management for hepatitis C. In testing, if possible, conduct a baseline testing for anti-HCV of the source person. Baseline and follow-up testing for exposed HCP should include the following. 1. Baseline testing for anti-HCV and ALT activity. Follow-up testing for anti-HCV and ALT activity at 4 to 6 months. For a quicker diagnosis, conduct an HCV RNA test at 4 to 6 weeks. If the anti-HCV test yields a positive result, check for ALT or alanine aminotransferase level. A high ALT level indicates liver inflammation. For the treatment, an HCP who tested positive and who has a high level of ALT should be referred to a specialist. Pegylated interferon and ribavirin has a response rate of 40 to 80%. Interferon monotherapy may be substituted for ribavirin if there is a contraindication.